it's titled Implementing the Patient's Charter for Tuberculosis Care in High Incidence and Incidence Communities and Across Jurisdictional Borders. Now, I'll explain a little bit what the project is about, but mostly it conceptually, because it's a large project over a long period of time, and I won't get into too much detail. Of course, I'd be happy to answer any questions towards the end. And I do believe there's some folks here from the communities to say some things as well. So you guys, the Patient's Charter for Tuberculosis Care is an international document that came out over 10 years ago. It's a companion document to the international standards of tuberculosis care. It's not been implemented in Canada in any way. And I'm going to talk a little bit about it because there's some language in it which relates to TB patients and their communities, which is very relevant. So you guys, this project is actually a follow-on project to a larger project that was earlier in time, started back in 2006, CIHR funded project called the Determinants of TB Transmission in the Canadian-born population of the prairies. And that project, it was interesting. One of the major findings of the project was how focal the disease was across the prairies. And this slide just shows you basically that out of 199 reserve communities across the prairies at the time, there was only 47 of them that had over a 2-year period a case of TB that was in a position to transmit. And by that I mean an adult case that was culture positive at minimum. But as you can see here, some of these communities had a lot of tuberculosis. The red bars are smear positive and therefore more infectious. The blue are culture positive, smear negative. And these are not large communities. Many of them are quite small. And so when you've got a dozen cases of infectious pulmonary tuberculosis in an adult in a community of 1,000 or more people, that's a major crisis, actually. And so the other thing we learned from this, and it's not evident on this slide, is that it's a gross oversimplification to think that the disease is localized to just that community. Indigenous communities, and I'm speaking to folks who know a lot more about this than I, but they're often not just isolated, remote communities all by themselves. There may be a reserve community close to a non-reserve community, such as a northern village or Métis settlement. There may be an inner city population that connects to the Indigenous communities. And so these cross-border issues are huge because there are jurisdictional boundaries that have colonial roots that dictate how care is delivered in these different contexts. And that makes it very, very complicated. So, so the pathways, we thought, we were very interested in this Pathways Initiative. It's a CIHR signature initiative, and Malcolm King, who's here today, was instrumental in getting this off the ground. It's a huge project. One of the requirements of the project is you had to be working in a sort of a heterogeneous group of communities, whether they were geographically or by designation or the jurisdictions responsible for their care were different. And so you had to have a group of or cluster of communities, and be looking to intervene in those communities in ways that were common to them all. Now, it just happens that in northwestern Saskatchewan and northeastern Alberta and NAMD, some of the communities NAMD spoke about earlier are amongst those. There's a cluster of communities that, for practical purposes, from the community's perspective, these communities are not separate. They're historically, linguistically, culturally very connected. The people move around between the communities. They have relatives in one community, relatives in another. And to think of them and to deliver care in them in a sort of siloed manner, because one is a reserve and one is a Métis settlement and one is an inner city, is doomed to fail when it comes to tuberculosis, because you have to think of it as not being basically unsuccessful. If you were highly successful in one community but not in the other three, let's say, and you're working in 4 communities, then you're bound to fail. So you have to succeed in them all. But the jurisdictional boundaries actually they actually prevent that, or they run counter to that working together. So in our Pathways initiative, Pathways project, there's these 4 exemplars that you could apply to. Of course, we applied to tuberculosis, and to increase research capacity and implementation science related to the health of Aboriginal peoples and other vulnerable populations. Malcolm may want to say something about this at the end, but this Pathways initiative, it's in 3 components. And the first component was basically team building. So for a year and a half, we worked in these 4 communities to try to build a team. And each community decided who would be the coordinator in their community. A community member would lead the project in that community, and we built this team. And then once you had built the team, you could apply to the second stage, component 2, which has these sort of objectives: strengthen the effectiveness or scalability of interventions in the 4 exemplar areas through community-informed enhancements, support teams to study the enhancement and or adaptation and scale-up of population health interventions. So we view the coalition of that we have created, this forum for advocacy and for community-led collaboration. We review this forum and the governing processes related to it to be our scalable intervention, if you will. So coming back to the title of the project and sort of the concept behind it, this document, if you read it carefully, has some wonderful language in it that relates to the rights of TB patients and the rights of communities. This is just a little excerpt from it. But this and other rights-based documents, notably Article 23 of the UN Declaration on the rights of Indigenous peoples, if you look at Article look at the TRC and number 18 in particular in the TRC, these are rights-based statements. So we're saying, I guess, in this project, that it's time that the rights of the individuals in these communities be asserted. And so through this project, we hope to do that. Now, so these are these other rights-based, the other call to action 18. If you read those carefully, you guys, it's very strong language, actually, which should empower communities. Historically, it hasn't. In TB control, TB prevention care has largely been a top-down endeavor from traditional stakeholders, whether it be provincial governments, FUNIB, but the community is kind of a passive actor in all of this. We believe very strongly that that has to change, and that ultimately the community needs to be central to decisions that are made inside the community with respect to this disease. And we're trying to, through this project, do that. Like I say, we're working in these 4 communities in northeastern Alberta and northwestern Saskatchewan that are very connected from the point of view of the community. The communities themselves, they're not separate, but there are huge barriers there that are jurisdictional and, like I say, largely have colonial roots. And so by trying to work across these communities, we're trying to basically decolonize this aspect of tuberculosis care and put the communities themselves to give them an equal, to give them a seat at the table to begin with, which is basically equal to the other stakeholders, but ultimately central to it all. And that's a process, and we're hoping to work on that. So now through our working in this coalition, we asked the communities, so each community has a community co-investigator and other representatives. We asked them what sort of local level interventions could this project do for them. And so the first one they chose was this, to shift from a centralized approach in which local data are deposited into national databases for aggregated analyses to a bidirectional one in which the local partners have the capacity to collect and analyze data and then use the data to design locally responsive interventions. So the communities wanted to know what was going on with respect to TB inside their community. They want to be informed, they want to be educated about what the data means, and they want to be able to participate in any decision that is made in their communities with respect to this disease. And so that means building almost some infrastructure within the community to do this, because although there is infrastructure there, they historically have not had a seat at the table. And so it's a work in progress, but we have some wonderful community co-investigators and others from within the communities who are so supportive of this, and we are confident we will ultimately make it happen. This bidirectionality, historically information has been gathered at a community level, it's rolled up into national databases, and we talk about the data, but really very little of it gets back to the community, and so they understand what is actually happening in their community and can be part of any decision about how we actually change things. And let's face it, they know their communities better than anyone else, and they know what might or might not work. And so engaging them in this way, we believe empowers them. We believe it also, by owning the epidemiologic narrative, we recognize that that's eventually a political act, and so it has it has the effect of empowering communities. In theory, we believe. Some of this, of course, is yet to kind of come to fruition, but it's a work in progress. The other intervention, and then I'll stop, is an expanded program of outreach. This is similar to what Namdi was referring to earlier and what's happening in Nunavut with respect to time of TB. But it's also, through this outreach, we believe that we can train and build capacity within the community for it to look at questions of its own. For example, I've just said to you guys that we believe mobility is huge amongst these 4 communities, and we can't think of them in isolation. And so, but we could easily kind of measure that, and so the people and the membership of the communities can begin to appreciate how much mobility there is and how important it is for them to work together, to train members of the community to undertake qualitative research. We think is possible, and that they can do this. And we believe that mobility issue, just as parenthetically, you guys, is huge. A number of you, and I know Pam back there, she'll remember, a number of you will know that in the past, in Alaska, for example, they went into communities. These were extremely remote communities, and they went in there proactively, and they basically removed TB. They screened the entire communities. They were very aggressive. I don't believe that approach by itself can work anymore, simply because things are more complicated. There's so much mobility that it's hard to think of these communities as being isolated and disconnected. They aren't anymore. At any rate, I think that might be my last slide, and just thank all our funders and partners and so I think, Stephanie, I don't know if you or Sherry or Rita want to say a few things.
So I guess first I want to start by echoing the sentiments of everyone who came before. I'm just very grateful to be here. It's a good reminder of what I've been in this position in La Loche as a TB nurse for the last 6 years, and sometimes it kind of feels like you get to a point where you're spinning your wheels. So it's nice to be here and, light a fire under myself, just listening to everybody else's presentations and stories. So we were asked to talk about one of the initiatives that we have happening in La Loche, which is our outreach days. There's a team of us who work together collectively to bring these to the community quarterly. Excuse me. So what happens is, maybe I'll step back a bit. So there's an area in La Loche that is known as the jungle. So there's the liquor board store. Across the street there's a lounge, and right next to that there is a sports bar. So in this area is kind of where people congregate in the morning and hang around, and basically they go in, once they get their alcohol, go into the bush and do what they do. They drink and just hang out there. So of course, when we're looking in our community at our vulnerable population and all of the social determinants of health, this is the group we're looking to target. So essentially what we've decided is, instead of waiting for them to come to us, we've taken our services out to them. So there's a church very near there, which works in our favor because, proximity, it's good. It's equipped with a kitchen. So what we've been doing is we've been offering a meal to these folks. In return, they give us a few minutes of their time and go through different stations that are set up. TB, of course, is what started it. So, of course, we've got a table there, and we do screening, sputum samples, collect sputum samples if necessary, ask about risk factors, TSTs if needed. And we've also got different team members that come and join us. We've had our diabetic educator there in the past. We have had, there's kind of the mainstays, I guess. There's public health. Public health will come with us and offer immunizations to the folks that need those. If flu campaign is going on, we offer flu shots at the time. We also have a community caseworker who, her area is HIV, so she'll do one-on-one talks about HIV. We've had our sexual wellness worker come out, and she's spoken to people about STIs, harm reduction offered in the community. So those are kind of the main folks that are at the events. We do have others who kind of come and go. And of course, mental health and addictions are also there. They don't really have a table set up, but they kind of are there as a presence to mingle and make connections with our people. So yeah, and then once they go through that process, then they have a hot meal, and we give them incentives as well. We have hygiene bags that we give to them, which, have a variety of things, but mainly it's, just the necessities like the shampoo and razors, and there's condoms in there and that type of thing, as well as, we give toques and mitts and warm socks. And last June, there's an area in town where people will go, I think it's around the end of May, early June, somewhere in there, where the fish are running. So last year we gave out snare wires so that they could snare fish and, provide for themselves for as long as that was the fish were running, right? So it's just whatever. The other thing I should mention is last June and this past November, our last two events, we had, we also introduced point-of-care testing for HIV, which I wasn't sure how that would be received, but it was very well received. We had 35 people tested on the first time we rolled that out. We actually had people coming in through our doors, leaving, and bringing people back. So people want to know what their status is, but they don't necessarily want to come into the health center is kind of what we're finding with that. So I think we've had about 60 people tested for HIV since we started doing the point-of-care testing at our events. So that's really encouraging. Am I missing anything?